Good day, everyone, and welcome to the webinar. We'll just give colleagues 1 minute to join, and then we'll start. Hi, good day, everyone. Welcome to the webinar. We are just giving colleagues 1 more minute, and then we will start shortly. Thank you. Good day, everyone. Let's begin. Welcome to the launch of the findings from the Survey 1 of the COVID-19 vaccine survey. A few housekeeping notes before we start. The session today is going to be recorded, and we will share the slides and the recording with you afterwards. We will be having a Q&A session for the last 30 minutes of the webinar. But throughout, please use the Q&A function to add any questions. Please use the Q&A so that the panelists see the questions and they can respond to them promptly. We have a really wonderful, diverse group on this call today from various backgrounds and involved in different aspects of the response to COVID-19. So we would love to hear from you throughout the webinar. We'd also love to hear any questions, comments, thoughts during the webinar, but also please feel free to email us, and we'll put the email in the chat. We ask that you please be respectful of everyone's choices, beliefs, when you make your comments and suggestions. So in the chat, you'll also see our CVACS Twitter account. So please follow us to get updates on progress with the survey and our results. So thanks again for joining. The COVID-19 vaccine survey was born out of the vision of the Bill and Melinda Gates Foundation and is conducted by the Southern Africa Labour and Development Research Unit at the University of Cape Town. Today we'll be presenting the findings based on partial data from the first survey. We will share some information about this, but due to challenges in recruiting people quickly to the survey, we have partial data to present today, and in early January we'll present the full results. Given us partial data, we have not weighted the data using survey weights. So please bear in mind that the results you are seeing are not representative of all vaccinated individuals in South Africa, but rather the individuals we managed to find in our survey. CVACS provides information and collects information on factors influencing COVID-19 vaccine uptake, including vaccine hesitancy and other demand-side constraints. Our goal is to provide timely information to policymakers and others involved in creating demand for the vaccination, so that our information can feed into those campaigns and do so as quickly as possible. Our study is designed to follow individuals over time. So we'll be re-interviewing individuals from Survey 1 in February so that we can understand who among the unvaccinated gets vaccinated and what motivated that decision. Our survey is also designed to test messages that are informed by behavioral science principles. In each of the surveys, we test 2 different messages to see if we can learn anything about certain types of communication and their impact on COVID-19 vaccine intentions. CVACS collects data through brief telephone surveys from a large sample of unvaccinated individuals throughout South Africa. So to be enrolled in the first survey, you need to self-report being unvaccinated. The survey instrument and the questions for the first survey were designed through a participatory approach using a crowdsourcing process. We wanted to ensure that our survey instrument was both relevant to and informed by the experiences of a range of individuals working at different parts of the vaccine rollout and on the response to COVID-19. The platform we used and are still using for Survey 2 is called Idea Notes. Colleagues are going to put the link to the crowdsourcing platform into the chat now. At any stage, you are welcome to visit the platform to suggest questions for our second survey and to comment on any other questions that have been posted. To make the survey most policy relevant, we would love for you to engage with the platform and add your suggestions. To maximize the value of the data, we are also sharing all data publicly and freely, and we are doing so approximately 1 to 1.5 months after the completion of the surveys. And we'll provide more information on that in due course. So the first survey started in the middle of November, and we are releasing the partial results today. We anticipate the data from the full survey 1 to be released in the beginning of February. We then aim to start the second survey in mid to late February, releasing the results about a month later, and then the data in about April 2022. So our fantastic team that you see on the slides here, we were supported by various colleagues at Soldier, including Nicola Branson, Kelly Arrington, Murray Labrant, Vilmore Ranchard, and Reza Daniels. And we were also supported by an amazing data quality team. So we thank everyone for their support and continued contributions. Our consultative group was pivotal in the design of the sampling and the survey from the start, and provided amazing input into the survey questions for Survey 1, and also helping to facilitate the crowdsourcing process. So we're really grateful for this group for helping to ensure that the findings are policy relevant. So we start with a brief summary of the key findings and implications, which we will then develop and build on as we go through the presentation. What we find is there are really 4 distinct groups in our sample based on their different plans and intentions to get vaccinated. And the barriers and facilitators among the different groups are quite starkly different, which really suggests that there's a need for tailored interventions for each of these groups, both to promote demand and in terms of service delivery. So the first group we find is what we call the as soon as possibles. This is 1 in 3 people. They believe that the vaccine works in general, but they have several barriers which are preventing them from following through on their intention, which is to get vaccinated. So several interventions are needed to make the vaccination process a lot easier for this group. Then the second group are the wait and sees. This is 1 in 5 people we find. These individuals do not, on average, believe that the vaccine works that well. So there's a low perceived vaccine efficacy among this group, and there's also a really sort of deep-seated fears about the consequences, the health consequences of getting vaccinated. So we really need to think about changing the mental models around what they're waiting for, so, and what benefits they'll get from vaccinating, and then to counter a number of deep-seated misunderstandings which are arising. The third group are the only if required group. These individuals look in many ways similar to the as soon as possibles in terms of reasons for not getting vaccinated, but they have far lower motivation. They don't see the benefit or need, but they may be less likely to push back against any kind of requirements. The fourth group are what we call the definitely nots. Among this group, there are very large fears and misunderstandings about the health and safety of the vaccine, and they don't believe it is effective. So in terms of this group, given there are such large misunderstandings, the interventions may be needed to address these to prevent them from spreading. So back to the start. So the sampling strategy and survey design was created through discussions with various groups. We used the Credit Bureau database as a sampling frame. This database collects all information on people who have a credit check run on them, whether or not they applied for credit or whether or not they received the credit. So there's a large range of different South Africans in this Credit Bureau database, including a lot from low-income areas. For example, when people apply for credit from low-cost stores. So we took this database and we overlaid it with EA level and Census 2011 information. We then created different strata, and so we stratified on a measure of wealth and well-being called the Neighborhood Lifestyle Index. We stratified on location and population group and gender, and then to ensure that the sample had age groups which mirrored how the vaccination program was rolled out in South Africa, we stratified on the specific age groups. So we did random sampling among the strata, and we used disproportionate sampling to make sure that there was enough representation in the smaller subgroups and in the over 60s. So our initial recruitment strategy was to call individuals and speak to the exact individual from the database that we pulled. And we found that in general we were reaching mostly we were reaching the same person that we had the contact information from. What we realized quite soon on is that we were already struggling to enroll individuals into the survey. Many people were very hesitant to speak about COVID and speak about vaccines. And we also found a much higher than expected level of self-reported vaccination status. We had about 75% of individuals we spoke to reporting that they had been vaccinated. So we revised our strategy to make the survey more anonymous, and we also had to ramp up our survey operations, given that even making it anonymous, we still found fairly high and higher than expected reported vaccination levels. So, given our initial challenges finding respondents, by the announcement of Omicron, we had interviewed 157 people. So this created the opportunity for us and for learning, given that now most of our participants and most of the interviews were conducted in the period after Omicron was announced. So as of 11th of December, we had 1,940 interviews completed, and these are the results that we report on today. We are aiming to complete the full survey by the end of. The surveys were conducted across South Africa, and we see on the map on the left that more surveys were conducted in more populated areas, and that we have representation across all provinces. In terms of the types of households in our survey, we have half from either township or informal areas, 29% from formal residential, and then the rest from more rural areas. The sample is more predominantly young individuals. We have 800 individuals interviewed among the 18 to 34-year-old group, but we do have a lot of surveys, over 500 among individuals 50 and older. The gender balance in the sample, we in all age groups except for the 35 to 49, we have almost an even split of males and females. With the 35 to 49-year-olds, we have a slightly greater proportion of males. In terms of socioeconomic status, we find that 60% of our sample earned money in the past week, 63% had completed matric or grade 12, and 29% had medical aid. The numbers completing matric or grade 12 and the numbers with reporting health insurance are slightly higher than found in other surveys in South Africa, and this was expected given that we are conducting a telephone survey and likely to find individuals who are on average slightly more well off than the general population averages. Looking at the total household income that was reported in the last month, almost 60% of the sample reported an income of less than 5,000 Rand, which is about $312 today. We do note that there's 25% of the sample did not provide this data. And one implication of that is that we see an association between owning a vehicle and not reporting income, which is indicative that the data we see here probably means that the sample is actually a little bit more wealthier proportionally than is presented on this slide. We found that 18% of the households had gone hungry in the past week. 68% did own an internet device, and this finding suggests that related channels of communication may be effective in reaching the individuals in this sample. Approximately half the sample reported having sort of first-hand experience of the serious health consequences of COVID-19, saying that they knew someone who had died or got very sick of COVID. 16% reported having had COVID themselves. And then on the chart on the right, amongst individuals who reported living with other household members, we asked them if any one of them were vaccinated, and 57% said that yes, at least someone else in the household. Sorry, 43% said yes, at least someone else in the household had been vaccinated. The blue segment on that chart on the right. So to get an idea of where the participants fell on in terms of their vaccination plans, we asked the specific question regarding the COVID-19 vaccine. Do you plan to get it as soon as possible, wait and see, only get it if it is required? For example, if it is required for school or work, or definitely not get it. We find that 34% of the sample reported as soon as possible, and a fifth reported that they would wait and see. So encouragingly, the more than half the sample are on the scale of sort of easier to vaccinate to harder to vaccinate. They over half are closer to the easier to vaccinate side. This graph shows for each age group the proportion who fell into each of the intentions categories. For each of the intentions categories, the bar on the left shows the younger individuals, and the light blue bar on the right shows the individuals older than 60. What we see from this graph is that for each age group, about a third reported that they are willing to get vaccinated or wanting to get vaccinated as soon as possible, indicating that the intention to do so is sort of common across all the different ages. Looking at the only if required third grouping among each of the different age categories, we see that it's the younger age groups where the proportion reporting this compared to the other age groups was highest. So among the 18 to 34-year-olds, we find that 20% of them reported that they would only get vaccinated if required. An initial signal that requirement-related interventions may be best targeted to the young. Looking at the definitely no segment on the right, we see that among the older age groups, the proportion reporting definitely not is higher, and this probably reflects the case that as more and more people get vaccinated, the more of the unvaccinated left are more resistant to getting vaccinated. In terms of vaccination intentions by gender, this graph shows for each of the groups, males and female, the numbers and the proportions that reported and fell into each category of vaccination intentions. We see that again, more than 30% of both men and women reported their plan to get vaccinated as soon as possible. But we do see slightly fewer men reporting this. And looking at the last columns, the definitely nots, we see slightly more men reporting definitely nots. So some signal that it might be slightly harder to design campaigns to encourage and help and facilitate men to get vaccinated. So what we do now is we dive a bit deeper into two of the segments. We look at the as soon as possible group, and then we look at the wait and sees. So who are the as soon as possibles? This graph shows the proportion of each of the segments, the as soon as possibles, the wait and sees, only if required, and definitely not, who report in the orange bars having a household income less than 5,000. And what we see is there's a strong negative association between living in a household with income below 5,000 and vaccine intentions. So as soon as possibles appear to live in households that are less well resourced. And the same story appears when you look at the blue bars, which looking at the proportion who have medical aid. So the as soon as possibles are half as likely to report having medical aid as the definitely nots. So we have a sample where more of the resource poor individuals are reporting as soon as possible. We also know that our sample likely is slightly skewed to higher income and individuals with more resources because they have cell phones. So given that, we might anticipate that we have an underrepresentation of the as soon as possibles in our sample, or saying it another way around, that on the ground in reality there might actually be a greater proportion of the as soon as possibles that we haven't captured in the survey to date. So among those that reported they plan to get vaccinated as soon as possible, there was a relatively high perceived efficacy of vaccines. The orange bar indicates that almost 70% said that they think the vaccine will help prevent them from getting COVID. And the blue bar shows that almost the same amount, almost 70%, reported that they think the vaccine could help prevent them from dying. Subsequent to asking these questions, we asked a set of open-ended questions, and we allowed respondents to respond in their own words. We analyzed the responses to these questions using a thematic analysis. And what you see in all the graphs and all the figures that look like this is that we've taken the categories, and the categories that were the most frequently cited are in larger font. So for the as soon as possibles, the first question, one of the questions we asked them was, what is the single biggest reason that you have not yet vaccinated? And what clearly emerged was that the predominant reason was around access. Most individuals said that they have no time or they're too busy. Less frequent, but still related to access, many individuals reported vaccination site hassles, not knowing where to go, queues are too long, it's too far, don't have the money. After no time or too busy, the second most common reason for not having yet been vaccinated was concern around whether you could get vaccinated if you are currently sick or if you have a chronic illness. There was a lot of worry and fear about what would happen if you had a chronic illness like diabetes and then you subsequently got vaccinated. And this linked into the other category there, which is afraid or unsure or worried about safety. So a lot of concerns around safety emerging as well. Subsequent to asking the open-ended question, we posed a set of yes/no questions to look at different reasons for not having been vaccinated. So for each of these, we asked individuals, is it because, and then we asked them then the question and they could respond yes or no. Consistent with the results on the previous slide, we see that access issues were quite common for this group. 50% reporting no time, 25% reporting the site's too far away or the costs are too high, and still 20% reporting that they just don't know where to go. The bottom four bars indicate that they still worry about side effects, trust in the safety of the vaccine, which again is consistent with the previous slide on the main reasons for not being vaccinated. And then we found that almost a third reported that they believe that the vaccine may kill them. And we'll get back to that in a bit. We asked a number of questions to try and get a sense of potential interventions which could encourage or facilitate vaccine uptake among all groups, but we present the results here for the as soon as possibles. When asked, would you get vaccinated next week if someone could give you the vaccine at your home or place of work, we find 70% reporting that yes, they would get vaccinated next week. We also got signal that incentives such as vouchers may be effective among this group, with 60% reporting that if they got 100 Rand next week, they would get vaccinated. On the figure on the right, given that a large number of individuals reported no time as a barrier, we asked this subgroup whether they would have time if the vaccination sites were open at different hours. And 80% reported that they would get vaccinated, or they would have time to get vaccinated if it was open after 5 and if it was open during the weekend. So again, a story of reducing friction through increasing access. Other information which is relevant for potential interventions is that we wanted to know what the current understanding is about where you can get vaccinated and how easy it was, and the logistics around it. On the bar on the left, you see that 72% of the as soon as possibles reported that you can just go straight down to a vaccination site. But that means there was more than a quarter who thought they either had to register and wait for an SMS still, or they just simply didn't know the process. On the right, we see that the percentage not knowing that some pharmacies provide vaccinations was a third of the sample. So 2 pieces of information which could potentially be corrected through clear communications. So turning to look at the other segment, which is the group who said that they would like to wait and see. We compare this group to the as soon as possibles and to the other segments in terms of perceived vaccine efficacy. So within each group, the as soon as possibles, the wait and sees, only if required, indefinitely not. This graph shows the proportion who believe that the vaccine would help prevent them getting COVID and would help prevent them dying from COVID-19. And we see a stark difference between the as soon as possibles and the rest of the group. The definitely not, only 10% of them reported that they believed the vaccine would work. And looking at our next group of interest, the wait and sees, only 30% reported that they believed it would help prevent them getting COVID or help prevent them dying of COVID. So very, very different perceptions in terms of whether people think the vaccine works. In terms of the single biggest reason reported among the wait and sees for not having been vaccinated yet, again, the story of worried about safety appeared very strongly. So the largest and the most common category was individuals who are currently or have been sick, or again have a chronic illness. These individuals were really worried about what might happen and whether it was safe to get vaccinated when they have other health concerns or conditions. This also then linked into the second most common reason cited, which was afraid and unsure of safety. And a lot of the uncertainties revolved both around more minor side effects like headaches and things like that, but also then around worried about dying from taking the vaccine. Looking at the same set of questions on reasons why people had not yet been vaccinated. So compared to the as soon as possibles, we see a stark difference among the wait and sees, where access is clearly less of an issue among this group. with 25% reporting no time as a reason, and around about 15% not knowing where to go, or the site is too far away. And that is as a reason for not having been vaccinated yet. Much more prevalent were worries about side effects, about trust in the vaccine, and quite striking at the bottom, we see that 40% of the wait and sees believe that the vaccine may kill them. The story emerges from the open-ended responses that respondents gave to the side effects they are most worried about. And what you see here is that the side effects that are most concerning, or concerning for the most number of people, are really the more severe adverse events or severe adverse reactions to vaccination. The most common reason people gave was around fears of dying, and then a variety of individuals then reported a variety of concerns around getting sick. There were other really common reasons were worried about paralysis, breathing problems, and blood clots. So all told, these several groups point to sort of deep-seated fears around the health consequences of getting vaccinated. We then had a number of many individuals also did report that they hadn't been that the side effects they were most worried about were the more minor side effects, the headaches and body pain and fatigue. But the story emerging around deep safety concerns. Looking at the reasons why people said they don't trust the COVID-19 vaccine, there were a number of individuals who reported hearing stories, hearing rumors, lots of different information reaching people. Again, a lot of people were saying that they worried about getting sick. So these are exact quotes. People were saying most people they get sick and die. People are dying because of the vaccine. But what's quite striking is that a large number of individuals reported what they see as first-hand experience of this connection between vaccine and death. So individuals saying, my father passed away after getting vaccinated, or many people that were close to me died after taking the vaccine. A number of pieces of qualitative research are building the story that it's not necessarily misinformation which we need to address here. It may be more the case or that it's a misunderstanding. We have millions of people getting vaccinated, and as one would expect, with that large number of people, some individuals are going to get vaccinated, and then unrelated to the vaccine, they're going to get sick or die. And as people like to, or have a tendency to look for explanations for events, many individuals will make the association into a causal and believe that they are linked. Our responses to the various questions on potential interventions which could help increase uptake were consistent with the stories of deep fears and uncertainty around safety. We find that only 25% of individuals said that if someone could give them the vaccination at home or at work, then they would get vaccinated next week. And we also see amongst this group that incentives may not also be that effective, with only 20% saying that they would get vaccinated next week if they got a 100 Rand voucher after getting vaccinated. The figure on the right again looks at the subsample of individuals who reported not having time to get vaccinated as a reason they have not yet been vaccinated. And we find that among this quite small subsample of the wait and sees, that they believe they would have time to do so if the vaccination site was open after hours. Similar to the as soon as possibles, we see that almost a third of this group did not know that you can go straight down to the vaccination site, and a third also did not know that some pharmacies are providing vaccinations. Thinking about interventions which could potentially encourage individuals, we asked them, if there's one thing today that could convince you or help you get vaccinated, what would it be? And consistent with the story that has been unfolding in our data, the two main things which would help people are safety assurance and efficacy assurances. People want to know it's safe, and people want to know that the vaccine works. Of note, a number of individuals reported that one thing that would help them is if their doctor okays it. There's a campaign running in the Western Cape where doctors are having quite in-depth discussions with individuals, attending malls and providing talks and speaking to people one-on-one about their concerns and fears and about the vaccine. And this campaign, the initial evidence suggests that it's being quite effective, and it might be sort of those kind of in-depth engagements which might be needed for some individuals to get past these very deep safety concerns. Another potential signal on things which could help the wait and sees and the other groups, the only if required and definitely nots, things which could encourage them to get vaccinated, is the potential network effects that we are seeing in the data. So the orange bars look at the responses to the question, most people in our area have been vaccinated. The percentage of the as soon as possibles who reported that most people in their area had been vaccinated. And the blue bars look at the percentage of each of the segments that reported that someone in their household had been vaccinated. And here we see an association between vaccine intentions and sort of awareness of other people being vaccinated. So among the as soon as possibles, 55% had someone in the household who had been vaccinated, and among the definitely nots, only about 25% had someone in the household who had been vaccinated. So this provides some initial indication, and a lot more research needs to be done on this, that there might be some positive spillover effects of increasing access to the as soon as possibles. If the individuals who want to get vaccinated and have not yet done so because of access constraints, if frictions could be reduced and those individuals can be supported to follow through with their intentions, then they might provide the social proof that vaccination is okay to the others in their network and encourage others to get vaccinated. So I'm now going to pause and hand over to my colleague Alison, who's going to walk us through the next part of the presentation.
Great. Thank you, Brendan, and thank you for walking so carefully and clearly through these very rich results. It's terrific to hear it all in one place. I'm going to talk about something Brendan mentioned very briefly at the beginning, which was a short messaging experiment that we embedded at the end of the survey. This, again, in an attempt to be very policy responsive, gave us a chance to try a couple of messages that governments, local governments, health systems might be interested in trying, and see if they at least change the intentions or the predictions people have about their future vaccination status. So the way this worked was at the very end of the survey, right before the final questions and the wrap up, the respondents were assigned to one of three conditions. This just automatically happened within the survey that Ask Africa was fielding. We had three groups. One group got no additional message after the final question until our final prompt. And then two other message groups were tried. After the exposure to either the no message or message one or message two, the interviewer asked, reminded them, we'd like to contact you again in February 2022. By February, do you think you will have had a coronavirus vaccine? So asking them to sort of project a couple months into the future and just guess or estimate what their vaccination status will be. So that was our main outcome, to see if receiving one of these messages changed people's guess about their future vaccination status. The first message, building on what Brendan just shared around network effects, was what we call a social proof message. So we just reminded people how many other people in South Africa have been vaccinated. So we said over 15 million people in South Africa have already been vaccinated. And to help people imagine that, how big that number is, we said that's more people than everyone living in Johannesburg, Cape Town, and Durban combined. And then just to get them to think about that a little bit, we said, the interviewer said, did you know that? Didn't really matter if they said yes or no. We just wanted them to sort of think about how, had they thought about that number. And then just to enforce the message, the interviewer says, yes, I was surprised too, but it's true. With those numbers, you can really feel confident that the vaccine is safe and effective. So that was the entirety of the message one intervention. The second one, if you could advance, Brendan, was what we called our free and easy. We just really, really wanted to enforce that this vaccine is accessible and that it's free. And we used some messaging language that's been tried in other settings and that I'll share. So the interviewer said, just as a reminder, a free vaccine is available for you right now. Tried to sort of, the available for you gives them a little bit of ownership. Oh, there's my vaccine that's waiting for me. Reminded them you don't need to register or make an appointment. You don't need medical aid. You can go straight down to your closest vaccine site whenever it's open. And again, to prime some engagement with that message, we said, did you know that? Again, the next interviewer comment didn't depend on whether the person said yes or no. The interviewer then said, yes, they've made the process easier than it was before. Registering before or waiting for an SMS with an appointment aren't necessary anymore. Our results from this, on the next slide, Brendan. So with the y-axis of this graph needs a little bit better label, which we'll add before we send out. This is the % of respondents who say they imagine being vaccinated by February. And we're showing the additional % compared to the group that got no message, which I believe was around 42%. We got about an extra 2% from the social proof message and about another 5% from the free and easy, who, just having heard what the interviewer just told them about one of those two messages, said, yes, I'll probably be vaccinated in February. So these are only intentions. The nice thing about this survey design is because we will speak to these folks again in February, we'll actually be able to see if this very brief intervention actually changed, because this was a random assignment, changed the outcome of interest, which is vaccination. So at least, again, this is a bump, a movement of the needle on their intention or their plan or their imagination of their vaccination status after hearing the social proof or the free and easy message. And happy to take any questions about the survey in the chat or when we do Q&A. Back to you, Brendan.
Thanks so much, Edison. So in conclusion, going back to our key findings and implications. So we have 4 really distinct groups of unvaccinated individuals that are evident in our sample. And as we've seen, they face very different barriers to vaccine uptake, and therefore more targeted or tailored interventions are probably needed for the different groups. The as soon as possibles, we've mentioned that they have the intention to get vaccinated as soon as possible, but there's several things which are standing in their way of doing so. They believe that their vaccine is effective, so they so that they know the benefits. They just need help in converting their intentions into action. So it's very clear that we need to make the vaccination process really easy and frictionless for this group. It's probably not easy enough just to say you can go straight down to your nearest site. We probably need to bring vaccinations closer to people, to their homes, to places of work. Need to potentially open vaccination sites after hours, and really need clear messaging about the logistics and how you go about getting vaccinated. We saw that approximately a third of individuals across all groups still did not know that you can go straight down to your vaccination site. And given what Alison's just presented on the messaging, there's some signal that that kind of information might lead to slight shifts in intentions as well. We saw that the as soon as possible group are have a slightly lower socioeconomic status, or they live in more resource poor areas, which indicate that increasing access in these areas may be effective in reaching this group. The second segment we see is the wait and see group. Here, as we've seen, they have serious concerns about the negative health consequences of getting vaccinated. A lot of concern about whether they might get sick or they might die as a result of the vaccination. A lot of uncertainty about whether they can get vaccinated if they currently have a chronic illness or are currently feeling sick. These individuals also have a very low perceived efficacy of the vaccine. So right now they have these deep-seated fears, but they're not necessarily exactly sure of what they're waiting for. They're not sure what the benefits are. So there seems to be a need to both address the vaccine efficacy question, as well as look for ways to address some of the misunderstandings around the vaccine making people sick. You can't take it when you've got a chronic illness. Perhaps one way of doing this is we need to make it more salient that many people have been vaccinated and many people are okay. The third group, which are the only if required, we didn't present much data on them, but what we do find is that in terms of their reasons they give for not having been vaccinated, they are quite similar to the as soon as possibles. They also face access constraints. They also report similar reasons. But what we find, which is a stark difference among this group compared to the as soon as possibles, is not many of them think that the vaccine works or the vaccine is relevant to them. So given they don't see the benefit or need, the motivation seems quite low. But among this group, there may be less pushback against mandates, and there may be potential to think about interventions related to restrictions among the younger group, amongst which there was a greater percentage of the only if required at around 20% of the youngest group. And finally, the definitely nots. We see that they have really large concerns around safety as well. The percentage reporting that they believe the vaccine will kill them as a reason for not having been vaccinated was close to 70% among this group. So there's a need to really address misunderstandings among this group, especially to prevent them from spreading. So looking forward towards our second survey, as mentioned in the beginning, we are crowdsourcing questions to make sure we collect the questions which are relevant to people working on different with different backgrounds and on different components of the COVID-19 response. So our team's going to put the crowdsourcing link into the chat box again. We would really value hearing from you what questions you think we should ask. We know we're going into a period over the December-January holidays where there's a lot of campaigns, a lot of focus on increasing vaccinations, and what we wanted to do is come back in January, take a look at what happened during the holiday periods, what was successful, what was not, and hear what challenges you are currently facing at that time, which you would value information on to help design the next push for demand creation. So please do visit the platform, and when you do, you'll be asked to enter your email and a password. That password is not something that you have created beforehand. You can just put any password into that. So yeah, we look forward to hearing your thoughts and developing the second survey question, which will then be implemented in February next year. So we're really grateful to Ask Africa, who's the company conducting the survey telephone interviews, working tireless hours through the evenings and on weekends, so that we could have sort of the most timely information on COVID vaccine hesitancy and beliefs, or just in the period after Omicron was announced. So we really appreciate all the efforts. We're also really grateful for respondents who provided their valuable information and the time they gave us. As part of participating in the survey, participants were entered into a lucky draw where they could win vouchers, and the lucky draw will be made later this month. We'll be drawing the winners later this month. As mentioned, our second survey is planned for February. We look forward to hearing your thoughts and questions on that. And please do feel free to follow us on Twitter. So thank you everyone for listening. I'm going to now hand over to the moderator to walk us through any questions that have appeared in the Q&A during the session.
Thank you. So I'm logged in with the CVACS profile at the moment, but my name is Kim Engel and I'm one of the members of the CVACS team. If I can just ask, Tim, can you put your camera on? Thank you. Cool. So each of the panelists, Catherine, if you can also put your video on when you're ready. I'm going to ask a couple of questions that came up during the presentation. Most of them, I think we've answered in the chat already or in the Q&A, but I think some of them we could explain a little bit more about, because some of them we can explain with a one-sentence response, but it's a bit challenging to think about some of these things. So one of them that I was thinking about, maybe we could tell people a little bit more about, Tim, is the vaccination rate that we are seeing in our sample. We've had some discussions in the team as to why we think we're seeing a reported vaccination rate that's a little bit higher. Do you want to maybe share with attendees what we've been thinking on that?
Sure. Good afternoon, everybody. So the main thing we've been looking at, or sort of really thinking about, is the sampling frame. So the sampling frame is as Brendan mentioned earlier, for anybody who's had a credit check run on them. So we think that they might be a slightly more engaged in the sort of more formal sector of the economy, and therefore vaccinations would be higher in that area. But again, it's also self-reported vaccination, so it could easily be just the stigma that when they get the call from Ask Africa, that they believe they should be saying yes, that they are vaccinated. So it's quite difficult to actually figure out which side of the line they fall on there. But yeah, thanks very much.
If I follow up briefly, you know, that latter explanation would also explain a question that came through, which is, how is it that we have people who say as soon as possible, but also say, I fear the vaccine will kill me? So that could be driving some of that noise, which I think is really informative noise in this case.
Yeah, and just on that group who's saying that the vaccine might kill them, I was mentioning in the answers. So I read through all the string responses that people gave for why they don't trust the vaccine or what side effects that they're worried about. And some of these people that are saying that they're worried about death, some of them are saying the vaccine will kill you. So it's like they feel quite definitive, or at least that's how it's written down. Some of them are also saying, oh, I've heard of some people being killed. You die, you can still die from COVID. And that's more of the effectivity side. So I think that it is quite a complex issue that people are trying to grapple with making this decision and whether it is best for them, because there's a lot of information around. Yeah. And then Brendan, I was thinking maybe you could go ahead.
I see John from the Gates Foundation has put a comment in the chat saying we are seeing improbable high self-reported vaccination status in many contexts beyond South Africa, which suggests that perhaps part of our story is around self-reporting bias and people feeling like the desirable answer, or the answer that will make them look more favorable to the interviewer, is to report having been vaccinated. And I think we wanted to do a lot more work on thinking through this, because the one hypothesis is that the type of people who might have the inclination to report when they haven't been vaccinated, they may not be there as soon as possible because they want to get vaccinated. They may not be the definite no's. So there's potential that the individuals we're missing through the self-reporting bias are those who are feeling a little bit bad about not having been vaccinated, and may fall more into the wait and sees. And I think that's a positive spin on the potential bias from that.
Then there was another question that I thought was somewhat, it's difficult to think about as well, but we've also had some discussions about this, is thinking about this definitely not group, and how I remember when we were going through the analysis and we saw the graph of the different age groups and seeing how the definitely not group was higher among the higher age groups. So Alison, I was wondering if you wanted to chat about that a little bit and what we think on that.
Sure. I mean, I think that is a reflection of where we are in time in the rollout, because older adults have actually had a much longer opportunity to be vaccinated. And so by now, as we're calling and screening for vaccination status, the sample we end up with, the unvaccinated, by definition among the older group, are going to be the folks who've passed up that chance up till now and probably feel more strongly about, nope, never, have been asked a million times already, not going to do it. So my hunch, my demography training coming in, is that that's a temporal effect, given how long people have had the possibility by age to be vaccinated.
I see there's a question in the Q&A at the moment, and it's from Julia, and she says, thanks for a very informative presentation. In terms of network effects, is there a way to add age into that analysis? In other words, are young people more likely to get vaccinated if peers or other people are vaccinated? Or do younger people who are hesitant respond better to older people being vaccinated? Does anyone want to take that one?
Different context, but I can weigh in a little bit on the US context that we've certainly tried a lot of peer effects for teens specifically, not for 5 to 11-year-olds who are just recently eligible in the US, and not so much for older, but in the sort of 12 to 17, lots of TikTok videos and teen vax ambassadors, with the idea that even regardless of what the older adults in your life are saying, what's really going to be important to you is whether your friends and other age similar peers are getting vaccinated. So I think that's definitely worth a try here as well. That's a group that particularly responds to what's going on with their peer group.
Thanks, Alison. I see there's another question from Kate Alexander in the chat, in the Q&A, and she's saying, I doubt the formal side is valid. Is it possible that people who are vaccinated are more likely to complete the questionnaire? Catherine, you had a look at the descriptive statistics of our sample, and I remember us seeing some interesting trends there. Do you have anything to add on that?
I must first just clarify, Kate, formal side. What do you mean by that?
Okay. I'll just need to unmute her.
Okay.
Okay.
You spoke about the formal side of the economy in relation to the sample.
I think with the Credit Bureau database.
Okay, I gotcha. Yeah. I don't know. I think that people who are, there are two things here, in terms of how hard it was for us to get our sample and how that's still ongoing. And that, yes, it is a slightly selected sample in terms of these are people who are more active. And then the question is, when you report being vaccinated, are you reporting being vaccinated because you think you should, because you actually are, or because you just don't want to talk to us? And you have a feeling, although we're careful, but you have a feeling that maybe if you say that, we will go away. So those are three things which can add up to that very high vaccination rate. I don't think we've had many people who are actually vaccinated. I actually looked at this yesterday. There are 10 people who live alone who report living with somebody who is vaccinated. So that's just a little data thing. Yeah, hopefully I've helped with the question.
Thank you.
I think that underscores too, this is not a prevalence study. We're not expecting that from these data, but what we have is this really rich comparison within our sample across the groups by at least their stated vaccination intentions, to think about sort of generating, tailoring, and targeting strategies.
I see that there's a question from Jackie asking about the COVID prevalence in our sample. So she says, it looks like only 16% had previously had COVID, which is low considering the seroprevalence. How do you think that impacted the responses or the sample selected, i.e. perhaps some sort of bias? Brendan, do you want to chat on that one?
Thank you. Great question. So I think it was 16% who reported having had COVID. The rates. I think what's interesting about that is a number of individuals will report having had COVID if they perceive they've had COVID, rather than not there's been a confirmatory test. At this stage, I don't think we have a clear hypothesis on how these data might be influencing the results. I don't know if anyone else in the panel has any thoughts on this. Over to you.
Just a small thing, but very definitely, if you find somebody who's more likely to be unvaccinated, they're definitely less likely to have been affected personally by COVID. Yeah, definitely. So that might be explaining our slightly lower rates, but yeah, the percentage of people in the country who've had COVID, it would be nice to know that number.
Yeah, I think there are also some people who might think they had COVID and they didn't have COVID. It's also the perception of whether they think they had COVID as well. It's definitely playing a role here, I think. Julia has a question. She says she works for Section 27. I'm not going to read her whole question because it's quite long, but she's asking about compulsory vaccinations and people asking about that during their workshops. And she's saying that she's interested to see from the data that 15% of participants would get vaccinated if they're required. And she's asking, would that be from the workplace mandates or would softer mandates like barring access to sports events, bars, restaurants motivate people to get vaccinated? So on that one, I read through the responses to people, responses by our respondents in the different groups, and what they were saying might help them get vaccinated. And one of the things that people said might help them would be, and this was highest, was the biggest theme that came out of this if required group of people. And they said a variety of different types of things that might require them to get vaccinated. Some of it was if my work requires me to do so. Other ones were if I'm not allowed to go to certain types of places, if I want to travel. Other things say, well, if vaccinated people aren't allowed in public. So it does seem like there is a spectrum of ideas that people have about mandates and what would motivate them to get vaccinated. Another thing that was quite interesting that came up in these responses was talking about vaccinated people having to still, like some people are perceiving vaccinated people wearing masks as, well, they're vaccinated, they still have to wear masks, they still have to follow the rules about social distancing. So I think there's also this perceived, although it's not, that wouldn't be like a mandate, but it would be different requirements for the vaccinated people as well, might help for some people in our sample. But that's just on the first part of your question. I'll just continue your question and pass that on to someone else in the panel. She's asking a related question to this, is do mandates or the prospect of mandates further alienate some people from getting vaccinated? Essentially, might people who are on the fence about vaccinating resent the imposition and refuse more outright? And one thing here is that there definitely is a group of people who, just from the string responses that I saw, people saying that the reason that they don't want to get vaccinated is because it feels like they're being forced. So there is that opposition to it in the string responses that I've seen, but I just want to hand over to anyone else in the panel who might have something to add on this.
Thanks, Kim. I think what is quite clear from the definitely no group is, and in part from the wait and see group, is this very low perceived efficacy of the vaccine. So these groups are not perceiving that the vaccine is going to give them any benefit or any need. At the same time, there's really, really strong fears about what could happen to them if they do get vaccinated. So one of the potential implications of that is that if many individuals are asked or mandated to be vaccinated, you're going to have individuals who are perceiving that what they are being told to do might really harm them. And on top of that, they don't see the benefits. So I think, given our data, that there could be a number of individuals who might push back against mandates, and just, I think any considerations around requirements and mandates really need to bear in mind that there are these misunderstandings and people are really fearful. So if there are any kind of requirements, I think that needs to go hand in hand with efforts to try and address those misunderstandings and make people feel more comfortable about what they're being told to do.
And I'll just say to Julia, this is definitely going to be an area where we're going to want to ask some questions in February. So please, if you have thoughts about how to ask those questions, go put those in idea note, so we can make sure to figure that out. Kim, should we go to Zamir, who's got his hand raised?
I was about to. Yes, please. Zamir, I see you have your hand up.
Hi, colleagues. Thanks. Fantastic presentation. Good timing when I think we're all scratching our heads on what to do next. I really liked the focus on actually, what can we do? Alison, thanks for the kind of last snippet, and interesting to see like one question can potentially shift that many people to, in a sense, shift their intention. I did have a question on the extent to which the perceived requirement on registration and appointment is actually a block, because that's something we can do something about, right? I think we can be a lot crisper in the communication around don't wait, no need to register, go to your site. Or is it actually, Brendan, something that you touched on, which is actually we need to go a step further. We need to say no need for appointments, no need for registrations, and here's your nearest site. Click this link. And I think that so the sites are loaded on the system somewhere, may not be as easy to find, or the information about that's just not accessible. So just trying to think through, even with the existing set of constraints, what's the kind of perceived barriers that could be unlocked with some smart communication?
Brendan, do you want to respond?
Thank you, Samir. Really great question. I think there are a number of pieces here. And some of them speak to sort of the need, as you say, on clear communications on the logistics. We have a scenario in which the information people are receiving over time is changing on a number of different aspects on the pandemic, and one of those is that initially there was this understanding and message that you have to wait, you have to register, get an SMS, and it seems like that is still something which is causing confusion among maybe a third of the sample. So it does seem that very direct, clear messaging around that would be useful. I think I'm not sure exactly what the percentage, but there was definitely some individuals who still did not know exactly where they would go. So I think there are some clear messaging around that. Around some pharmacies provide vaccinations. So a few logistic areas where communications could help. I do think that the numbers of individuals who are reporting not having time and other constraints, I think that this communication on logistics could definitely help. But I think one of the lessons is that we may need to make it easier for people, even who know that they can go straight to the clinic, to be able to get vaccinated. So there's still a lot of people who know you can go, you can go straight down, know where to go, but they just don't have the time, or it's too far away. So I think a combination might be effective.
I'll just add briefly, there is a group of people, there's a lot of variation here, a lot of heterogeneity. There is a group of people for whom an appointment is actually a really useful thing, especially if they vaguely have intentions or motivations to get vaccinated, but today's never the day to just go down, even if they know where to go and it's convenient. So we should think about other ways to close that intention behavior gap for people that might take the form of, hey, would an appointment be helpful? I can give you one right now for your preferred time.
So I'd like to just add, just in terms of, we can help people in terms of access, like here is your nearest place. Brendan, I think it was about 20% of ASAPs who didn't know where the nearest place was, which is a high number. We can tell them here's the nearest place. We can please open up on the weekend, say. But to me, there's a fundamental misunderstanding of what vaccines do. That yes, you can still catch it but there's a high chance you're not going to land up in the hospital or dead. And those two things are, they're not separated. We see those beliefs, those numbers are the same. So people are not understanding that your transmission, you can still catch it, but your chances of getting it are much, much lower. Like, people are viewing the benefits of vaccines as only, it'll hopefully stop me catching it. Yeah.
If I can add to that, we're also seeing in the strings quite a clear message coming through from a lot of people when we've asked them, when are you planning on getting the vaccine? They're saying when I need it, when I need the vaccine is when I get it. But there's kind of misunderstanding that the vaccine is somehow a treatment and not a preventative measure. And I think that that's not clear. And if we're talking about communications, being really clear about the fact that the vaccine is a preventative measure, and you can still get sick, but it's going to prevent you, significantly prevent you from passing away from COVID. I think that's a very key point.
Agreed. There's a question from Kelly Jane talking about the Omicron variant, and I think this is an important point with our sample in particular. So she says that in the beginning, Brendan spoke about interviews, most of the interviews that took place after the Omicron variant. How much do we think that this new variant could have influenced answers? Do you think people could have been more hesitant with a potentially vaccine escape variant? And just on, before handing it over to someone else in the panel, one of the things, again, in the string responses from people was, especially more amongst the group, not the ASAP group, the people who want to get vaccinated straight away. Amongst the other groups, there's a lot of people saying things like, there needs to be more research. I'm not sure about these variants. Is the vaccine going to actually help me from stopping to get COVID if one of these variants comes out? So I do think that there is that definitely would have played a role, because people are hearing about all these variants, and they also mentioning things like the information keeps changing. Where are these variants coming from? So I think that there is a science communication aspect that we need to try and improve on, in talking about the degree to which it may evade vaccine immunity or not. And yeah, so anyone else in the panel want to add to that?
Just on the point that there seem to be a lot of people that still believe the vaccine is in its trial phase. Again, coming to the string answers, where we get a lot of people saying, well, I'm waiting for it to come out of trial, I'm waiting for it to stop being an experiment. I don't think it's been made clear enough that it has been approved, and that we're definitely out of the trial phase, and that it is safe for use.
Cool.
I was just starting to type a comment that maybe will be useful for everyone. Kim and Tim, I don't know if you want to clarify what you mean by string responses. Not everyone may not know what you're talking about.
Do you want to explain?
Sure. So string responses are the open-ended questions. We will ask a very general question, and we'll allow the respondent to provide an unprompted answer to the question that we've posed, and that's recorded by the interviewer in a text box. And those come through to us, which we then read and interpret.
She mentioned that we will, so this is quite a challenging part of the analysis to do, because it is a lot more qualitative to try and group themes together. And that's why we try to use a thematic approach to looking at the strings for this webinar. And also credit to our interviewers, because they interview in multiple different, all the South African languages, and then they have to record the answer in English. So it is quite a cognitively difficult thing to do during an interview, but it is incredibly valuable, especially for the first wave of the study, for us to collect new information. Although strings are difficult to analyze, they can provide a wealth of information, and especially on things where we're trying to explore something new. Just allowing the respondents to tell us an answer rather than making them choose from categories can be incredibly informative and help us see any blind spots that we may have.
Kim, can I come on briefly on the potential impact of Omicron, a number of different focus group discussions and other pieces of research throughout the pandemic has shown that as the science changes, as the situation change, people are getting inconsistent messages. First you mustn't wear masks, then you must wear masks, and for example, and then throughout the different messaging on the different information on the vaccines is very difficult for people to wrap their heads around. So currently with Omicron, there's a lot of science, a lot of debate around which of the vaccines are more effective, what's the impact of boosters, what's going to happen. And as soon as there's this inconsistency or uncertainty, there does seem to be a bit more distrust that develops in the information. The uncertainty likely also results or leads to a little bit more worries about safety, etc., etc. So I do think that every time there's a new development and it creates a level of uncertainty, we might have some individuals who feel a bit more resistant or hesitant. So yes, I imagine Omicron is likely to have some impact, but it's going to be difficult to work out what that is.
Can I do a quick jump in? Very quick, which is basically, there's been a lot of research which talks about vaccines and their effects, and then compares COVID and their effects, like what, and the effects of COVID, and shows that, the one is far worse than the other. So to me, in the questionnaire, there was that we didn't ask people, what does COVID do to you? So this is where it's going to be a bun fight, where we're going to fight to see which questions get put into the questionnaire. So I'm going to be fighting hard for that one. So please go to IdeaNote. The link is in the chat, and jump in there and put in your questions for survey 2, all the questions you had that we didn't answer.
In addition, you can sort of upvote or like other questions that other people have put in, and you can comment or improve or revise or refine. So it's very interactive. Even if you don't have question ideas yourself, you can still participate in voting on ideas.
I see we have 2 minutes left. So I see there's just answered the last question that has come through in the chat from David, asking about what about giving friends a voucher to take someone to the site. And I do think that there is a subsample of the group of people who have not been vaccinated who this definitely will help with. So for example, there was someone who, again, in these open-ended responses, there was someone who said, I'm blind and I need someone to take me to the site. One of the themes that I was actually categorizing around, it just wasn't that high to appear on the slides, but there were a few people who said, if someone would go with me, I'd go. So I do think that there is a small group of people where this would definitely help. Given we have 2 minutes left, Brendan, I'm going to hand over to you for closing.
Thank you. And David Matten in the chat raised a potential idea for how individuals could be encouraged, as Kim said, and we also value ideas for potential messages we can test in the second survey. So any ideas on messages which could potentially move the needle on intentions would be great to hear as well. So thank you so much everyone for joining this webinar. We greatly appreciate you being here. We're very excited to share the findings. We're looking forward to receiving all the rest of the data for survey 1 and sharing those results with everyone in early January. And then also, as mentioned before, just taking stock of what happens over the next 3 weeks in the holiday, so that we can think about what questions to take forward and contribute further to the efforts to increase vaccination coverage. So thanks to all of you, thanks to the panelists. I really appreciate all the contributions and questions and engagement. And we'll share the recording and the slides and be in touch with you again soon. So thank you and have a great day.